Thank you very much, Chair. I'd like to thank the organizers for this meeting, for inviting me to talk about the geographic diversity and management of CLL in African patients. I have no disclosures. The objectives are to assess the different presentations of chronic lymphocytic leukemia in Africans in relation to these criteria, and also to evaluate the different outcomes of treatment of CLL in Africans in relation also to these criteria. As an introduction, we've heard so much about CLL in the last few days. I think it's so mind-boggling for somebody like me who's come from Africa, where we have little or no resources to do any meaningful research. You will agree with me that CLL is a very complex disease to start with. And when you're talking about the African patient, it becomes even more complex. Yes, Africans have a lower prevalence of this disease. And in my search, I had to do a sort of literature search to do this talk because, as I said, we don't do high-tech research like you do. So this is Africa. You're all familiar with this. And when I'm talking about Africans, we're talking about the Black Africans. And when you look at the literature, it's either they talk about the Black and the non-Black, African and non-African. And so I'm particularly referring to those who are in the sub-Saharan Africa, the Black Africans. From here, you can see that Africa has a population of 1.2 billion people, and it's still counting. The first 9 countries in Africa, according to population, are listed here, with Nigeria being the top, most populous Black African nation. And that's where I come from. And when you talk about economy, we fall into the low and medium economy settings of the world. And that is a real setback for us. So during the literature review, I came across 14 abstracts or full texts from African countries between the years of 1984 and 2017. From Senegal, Ivory Coast, Nigeria, 7 papers, Cameroon, Kenya, which is a comparative, and now Algeria, also comparative, Uganda, comparative with the UK, and Zimbabwe. And I found 5 comparative articles from America between 2011 and 2016. There were many missing data. Now, this is the literature matrix. As you can see, this is, the red is not the hotspots in terms of gene analysis. It's the hotspots in the sense that these are the gaps in knowledge. And so you can see we have a lot of work to do to actually give you answers to what CLL really is about in the African patient. The blue squares, however, show similarity in the studies that have been done in those areas. So the summary of that matrix shows that the number of patients range from 1 case report to maybe 1,200 in any particular cohort for Africans, and for non-Africans from 60 to 4,000 and above. You will see that the prevalence rate for Africans is so much less than 1%. The median age is also lower than the non-Africans. Again, we see that male-female ratio is more in favor of females, which again we found to be rather variable in the sense that from country to country, from report to report, there are variations, even in Nigeria, of male-female ratio. When I was training as a resident doctor, I was made to believe that, yes, we have a cohort of young female patients who have CLL. But in our review, which we presented in the abstract for this meeting, a 5-year review of 10 centers in Southwest Nigeria, we found that the male-female ratio is actually the same. So things are changing, and it also depends on primarily the diagnosis. Diagnosis is key for CLL and any other disease. And we have to depend on clinical features and our morphology. Clinical features in the sense that we found in this review that lymph node enlargement seems to be more common in Africans than non-Africans. And then they tend to have more of the B symptoms too. This may, however, be related to the fact that they present late to hospitals. And also to say that most of the reviews that I came across, or papers that I came across, were hospital-based data. So community-based data are very few and far apart. So because they present late in stage binate B or C or RI 2 to 4, it may be related to the presenting features, which vary significantly. Laboratory investigations is key, or are key, to actually making a diagnosis and prognosticating the outcomes of CLL in any cohort of patients. So we found that Africans tend to have a higher lymphocyte count. But let me take you back. We have records or data to support that Africans tend to have a relative lymphocytosis in the first place. And this is probably due to infection, exposure, and things like that when the malaria zone. And on the average, as norm, we have a relative lymphocytosis. But lymphocytosis is usually a polyclonal type rather than the monoclonal B cell that is associated with CLL. There is a low median hemoglobin level because they come in very late. High beta-2 microglobulin has also been found in Africans when compared to non-Africans. Africans tend to have a higher LDH. Unmutated Ig genes have also been found to be more in the African patient. ZAP70 expression also, where it was done, very few centers could do this. These were the centers that did comparative studies and are equipped to do this. Again, ZAP70 expression was found to be significantly more in the African patient. Also, the chromosomal expressions, or these abnormalities, were also found to be significantly different and somewhat the same, depending on where you are and the data that has been published. So you have variations in the expression of the genes and the chromosomes, and immunophenotyping is something that we are trying to do, but from the review, a lot of centers could not do this. So maybe the lower incidence of CLL in the African may be due to misdiagnosis or lack of information to confirm whatever we see. As I said, we depend mainly on the peripheral blood morphology to make this diagnosis. So since we have relative lymphocytosis normally, when we now see absolute lymphocytosis, we begin to look for the features of CLL. So we screen patients. I looked at the studies that have reported screening of infections such as HIV, hepatitis, and the like. And a few of them have reported this, but very few data reported doing this. This is borrowed from YASA Blood in 2016 to show the diversity of the various cytogenetic abnormalities associated with CLL. So management of CLL in African patients. Treatment modalities generally are basically at the chemotherapeutic stage with a little bit of immunotherapy, that is with rituximab. We thank Roche for bringing rituximab to some African countries, and Nigeria is benefiting from that. Fludarabine and others also, together with the Fludara, are very expensive So it's only the privileged patient that has access to these drugs. Ibrutinib is not available in our setting. So the outcomes of treatment. Some studies have found no difference in the outcome or overall survival between African and non-African patients. These are the studies listed here. But generally speaking, it has been said that African patients do more poorly than the non-African patient. Is it because they present later, or is it because they have abnormal cytogenetic or molecular characteristics that predict poor outcomes? We don't know. African American patients were found to have shorter median event-free survival, even when given the same treatment environment. So that's saying something. So something is wrong somewhere, or something is causing the poor outcome of Africans when it comes to treating CLL. The overall survival of African patients, looking at studies from Nigeria, for example, show that it varied from 27.2% to 72% in 2 years. So again, very variable. 5-year survival, one compared to non-Africans, obviously was significantly less. And overall survival is around 152 months, whereas for the non-African is not reached. That's the Fauci et al. Study. So I also looked at risk factors, so to see which data or which reports actually considered possible risk factors for the different presentation and the poorer outcome. And low socioeconomic status, malaria, pregnancy, famine, immune suppression, exposure to petrochemicals, etc., have been considered. However, a study looked at SNPs in these patients and found that there was no significant difference between the two cohorts. So I have a question. Can animals have CLL? In the process of reviewing data, I came across this review and this information that yes, animals can have CLL. But hematologic malignancies have been reported in domestic animals, but reports of non-domestic animals are rare. And I came across this report of a 15-year-old female African lion. Can you imagine that? In Italy. And she had symptoms, and she was investigated, and she died very soon afterwards. And then her blood was tested, and she was found to have had CML. So what's the relationship? So in summary, I have presented Africans with CLL, a review that says that Africans have lower prevalence or incidence than non-Africans. They have diverse presentations, no matter their geographical location, have more aggressive disease. Male to female ratio is variable, but they are more likely to be female, especially when under the age of 55 years. They present late, have higher LDH, have variable cytogenetic and molecular abnormalities. And outcomes of the treatment of CLL in Africans, despite the same treatment conditions, is poor, and survival is less than 75% in 2 years. ZAP70 is a poor marker of prognosis, occurs more frequently in the African patient, and CLL patients, well, Africans tend to transform in about 5% of cases. So transformation. This is a group of patients in America who are learning to speak my language, which is Yoruba. They're now dressing like I dressed yesterday, and they are dressed in African dressing, but genetically non-African. Is that the same picture for the CLL in Africans? I don't know. So these are my references, and I want to thank the organizers again for inviting me to take this call, especially Anna Shu, who has opened my eyes or encouraged me to look at CLL into more detail in the African, particularly the Nigerian. Thank you very much.
So thank you so much for this review. So interesting data. We are going from one continent to another, and there are, of course, lots of problems to solve for you. But I think we are collaborative in this group, so we will find some ways to work together, I think.
Thank you very much.
So we have some time for a question from the audience. Any question? Yes.
Yes, well, thank you for that lovely talk. So, I mean, this is a fundamental issue because we don't know the original genotype. We know that Europeans have a very high incidence, Asians have a low incidence. So we need to know what is the prevalence or incidence. And I'm afraid that without a population-based registry, that estimates of incidence in Africa could be off by a half a log or even a log. I don't know if you agree with that.
Well, it's possible, but as I said, misdiagnosis or underdiagnosis may be a problem because we don't have registries as such.
Yeah, well, I wasn't really speaking about I'm really speaking about the fact that in our experience in China,
Right.
more than 2/3 of patients are diagnosed either because of a routine CBC or because of a CBC for some other thing like a heart attack.
Yes.
And so that you can be incredibly misled.
Exactly.
Without something like the SEER registry.
Yes.
So, but I think it is a fundamental question because we need to know if Europeans have acquired susceptibility or whether Asians have lost susceptibility. Okay. And it can really only be answered by knowing the true incidence in not African Americans, because they are fundamentally 50% European, but in Africans. And so I don't know if there's anything you can do about that, but that's the key question, I think.
Yes, it's very, very important, vital. And we've been able to obtain a grant now from the government to look into that in the southwest of Nigeria, where we have a team now of 10 centers who are going to participate in this prospective study to look at CLL into more detail and also try and correct that omission in terms of the gap of the prevalence and the incidence, and also probably get a database for a registry or database for our patients.
And a question from Peter Hillman?
It's just two comments, really. I guess one comment is that the median age, of course, in Africa is a lot lower than at the moment in the West, and that clearly will have an impact on the incidence of CLL. And the other comment is that I can't see Andy Rush in the audience, but he did a study, I think you referenced a paper in Uganda looking at the incidence of MBL in people with normal blood counts to see if, assuming that's a pre-leukemic condition, to see if the incidence, to get a true level of the incidence. And he found a similar level of MBL, but the MBL was different because it was marginal zone phenotype largely, with a much lower rate of CLL, I think in the region of maybe a quarter of the amount we see in the UK, which may represent antigen drive or some other genetic features which may suggest a lower incidence.
Yes, thank you very much. That's why we want to look into our population to see exactly whether we can replicate that or whether there's something missing. Yeah. Thank you very much.
And the last question?
I will congratulate you for telling us about the disparity in the knowledge of incidence, because we started with Professor Anna Schu's genomic map of Great Britain and other countries to your description of lack of information. And as Bob Gale pointed out, that there have been elegant studies of Chinese CLL in which very convincing studies of IGVH family usage are partly similar to Western European and American usage in CLL, IGVH families, and partly completely different, suggesting that from clonal point of view, the evolution of CLL in China and other Eastern countries is really complicated and different. And from there to go to your presentation in Africa, we have a long distance to travel to come to some kind of information. And as you said, that you are hoping to get some governmental grants, but those are very crucial, critically important, both from public health point of view, as well as the individual patient's welfare point of view. And I thank you for opening our eyes.
Thank you very much, sir.
Thanks very much.
Yeah, thank you so much. Thank you.